Welcome back, everyone. Today we are moving beyond the basic labels of anatomy and getting into the real action. We're talking about bone fractures, but specifically the tug of war that happens the second a bone snaps. Dr. Sarah, I'm ready to dive into the biomechanics of deformity. It's not just about the break, it's about what the body does next.
Exactly, Dr. Khan. From an academic and board exam perspective, it is a common mistake to think that the deformity you see on an X-ray is only caused by the initial impact. In reality, the final position of those bone fragments is heavily dictated by the surrounding soft tissues, specifically muscle pull and ligamentous attachments. This is extremely high yield for clinical rotations and the step exams.
I love that. I always tell my students, think of the bone as a tent pole and the muscles as the guy wires. If the pole snaps, those wires don't just go limp, they keep pulling. And because they're still under tension, they're going to drag those jagged bone ends into some very predictable, very messy positions. Dr. Sarah, why does this matter clinically? Why can't we just look at the X-ray and call it a day?
It matters because if you understand which muscles are attached to which fragments, you can predict the displacement before you even see the imaging. On a board exam, they might describe a patient with a shortened, laterally rotated leg. They won't tell you the bone is broken. They expect you to know that the muscle pull has already moved the fragments. Let's look at the classic example from the text, the fracture of the neck of the femur.
Ah, the old shortened and externally rotated special. I see this in the ER all the time. When that femoral neck gives way, the patient's leg looks like it's trying to point at the wall. Clinically, this is a red alert. But Dr. Sarah, break down the why for us. What's the academic secret behind that specific deformity?
It's all about muscle vectors. Once the continuity of the femur is lost, the powerful adductor muscles of the thigh pull the distal fragment, the whole leg, upward. That's why the leg looks shorter. Then you have the lateral rotators, which are incredibly strong. They pull that distal fragment into an external or lateral rotation. If you can't visualize those muscle attachments, you'll fail to understand why we need traction to fix it.
That's a perfect point. You're fighting against those muscles to get the bone back in line. It's a literal battle. Now, let's flip the script. Sometimes muscles and ligaments actually help us, right? The book mentions the ilium, the big wing of the pelvis. Why is a fracture there often less deformed than the femur?
That is a great distinction. In the case of the ilium, the bone is essentially splinted by its own surroundings. You have massive, flat muscle origins on both the inner and outer surfaces. These muscles act like a built-in biological cast. Even if the bone is cracked, the muscles are so broad and attached so widely that they hold the pieces in place. It's the opposite of a long bone, where the muscles act as levers to pull the ends apart. It's like a sandwich. The bone is the meat, and the muscles are the bread holding everything together. But we also have to talk about ligaments. They aren't just anchors. They can be hinges or even displacers. Dr. Sarah, how do ligaments influence fracture patterns in areas like the clavicle? The clavicle is a board exam favorite. In a mid-shaft fracture, the sternocleidomastoid muscle pulls the medial fragment upward toward the neck. But the distal fragment, that's where ligaments and gravity come in. The weight of the arm pulls it down, and the ligaments at the AC joint can keep that outer piece tethered in a way that creates a step-off deformity. You have to know which ligament is still intact to understand why the fragment moved the way it did.
This is exactly why you want to be the doctor of choice for your patients. Someone who doesn't just see a line on an X-ray, but someone who understands the forces at play. If I know the pectoralis major is pulling the humerus medially in a proximal fracture, I know exactly how I need to manipulate that arm to reduce it. It turns a guessing game into a precise mechanical procedure.
Precision is key. For the students listening, remember this. The mechanism of injury gives you the break, but the anatomy gives you the deformity. When you are studying muscle attachments, don't just memorize origin and insertion. Ask yourself, if this bone breaks right here, where will this muscle drag the piece? Exactly. If you're looking at a fracture of the olecranon, the point of the elbow, the triceps is going to pull that bone fragment straight up the arm. You'll feel a gap. Why does this matter clinically? Because you can't just put a cast on that and hope for the best. You have to overcome that triceps pull, often with surgery, to get the pieces to touch again so they can heal. To summarize for the boards, 1. Long bone fractures usually shorten due to longitudinal muscle pull. 2. Rotation occurs because of asymmetrical muscle tension, like the lateral rotators in the hip. 3. Flat bones with broad muscle attachments, like the ilium, are often stable. And 4. always check for ligamentous integrity, as they can act as the hinge for the displacement.
Beautifully put. Anatomy isn't static, folks. It's a dynamic system of tensions and levers. Understand the pull, and you'll understand the pathology. See you in the next session.